Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is brought to you by Apria. We know that the gold standard treatment for insomnia is cognitive behavioral therapy for insomnia. We also know that this is hard to execute due to a limitation in the number of trained psychologists. How can we make CBTI more accessible? Should we embrace alternative treatment models? Are we missing out on other behavioral interventions for sleep since we struggle to connect with behavioral therapists? What other therapies should we consider for our sleep patients? Dr. Richard Blackburn is a sleep psychologist who is attempting to improve access to behavioral therapy for sleep disorders. He is part of Nystrom and Associates, and they have 60 clinics through 5 states. He has a behavioral sleep training program as well as a telemedicine practice. He hopes to increase the availability of sleep behavioral therapy by increasing the pipeline and expanding access via telemedicine. He joins us today to share his model and discuss other behavioral interventions we may not have considered for our patients with sleep disorders. Thanks for joining us today.
Thank you for having me. It's an honor to be here.
So tell me about your CBTI program.
So I've been working in sleep for about 12 years, 13 years. And when COVID happened, all of us got laid off from the sleep centers. And so I wandered the world for a while and finally found a home at Nystrom's. And it's been wonderful because when I came in, they were already doing some training with Don Posner on basic CBTI, and he was running a consultation group. And when I came in, I said, I really want to expand on this. And they have fortunately given me the springboard to do that. So we began by training people. So I trained initially 19 providers in Minnesota to do the full fidelity CBTI treatment. And then we expanded it down to 11 providers in Iowa. And we're now starting our second cohort and planning a third. So it's starting to grow incredibly quickly, which is wonderful to see. And the referrals are starting to come in. So the program has been mostly train them, and then we do consultation and supervision, and it's just been a delight to work with these young therapists and to train them in a new modality.
So isn't it funny that all of the sleep people were let go during COVID, and then we learned about how much our sleep suffered during that time?
Yes.
Wow. So my understanding is that this field really hasn't grown very much because of poor reimbursement. Is that true?
Well, in a way, yes. So for most people who do CBTI or other behavioral sleep medicine, we're billing under the CPT codes for mental health. So it's not that it's different than other behavioral health treatments. It's just that behavioral health is not reimbursed very well. So there's no difference really between being a therapist or a sleep therapist.
So this was something, I think when Dr. Jennifer Martin was president, that she really advocated for this, for better reimbursement for CBTI. So are the limitations just because you can only bill behavioral health codes?
Yes. Yeah. And we're working to try to increase remuneration for our services, but that's really with each individual insurance company.
So I came across a study recently that demonstrated that CBTI delivered by nurses was effective. So it sounds like they read from the CBTI manual and the patients did pretty well. What are your thoughts about this?
CBTI can be done by anyone who has the appropriate training. So for people who are billing for those services, they have to have a way to bill for it. And so with nurses, they're a wonderful opportunity to do it, but how do they get paid for their services?
Yeah, I mean, you're exactly right. So it has to be somebody within the office that then is able to bill.
Yes.
So what about like a CCSH credentialed person?
Yeah, I love the idea. It's a wonderful program. I've talked to several people who have done it, and I'm not really certain how they're billing for those
Mm.
services. Um, so I can't speak much to that.
I think it's pretty heterogeneous. It's pretty heterogeneous throughout the US is my understanding. So, how do people apply to your training program then?
Well, initially we sent out an email to everyone asking if they would be interested in training.
Hmm.
And we that was our first cohort where we had 19 people from over 1,000 therapists who said, "Yes, I want to do this." And then
Wow.
as the program has grown and I've done continuing education for staff and various programs, we just get people who come forward and say, "I want to do this." So right now we're planning our third cohort, and I think we have about 8 people interested in the next round. So it's been very nice because there's this steady but slow stream of new clinicians coming on board who get the training and consultation so they can get right into practice.
So, are there other ways that we can maybe make CBTI more accessible?
Oh, there are a lot of ways. Uh, I'm actually going to be speaking at the practice management course in November
Oh,
on
fantastic.
this very topic. And yeah, so I mean, there are tons of providers out there. Telehealth after COVID opened up everything. So there's about 1,000 providers worldwide who are trained, and a lot of them have telehealth practices.
Hmm.
So one of the things people can do is they can either go to the UPenn provider list or they can go to the Society of Behavioral Sleep Medicine's provider list and find someone in their state who does CBTI via telehealth. There are also some wonderful digital CBTI apps out there. Sleepio just got FDA approval. And there's a couple other ones that are coming online, but Sleepio is kind of the big one right
Mm,
now. And there's new things coming online. So one of the things that we're now able to bill for is remote patient treatment.
mm,
And so there's a platform by Noctum Health that they call the Coast program, and it was developed by Anne Germain. It's a wonderful program, and basically, the person signs up and they get machines that send them learning modules, ideas, everything else, but there has to be a provider to okay it being sent. So the
mm.
machine generates the algorithms to apply CBTI appropriately. A provider then can click, yes, I agree with that, or they can change the recommendation. And according to Dr. Germain, you can treat a patient in really about 5 minutes a week. And so what this would allow people to do is it would allow those people who are trained and licensed in that state to do remote patient therapy. But because they're short sessions and the machine does a lot of the work, they're able to see more people. There are also new programs coming online. Dr. Lullaby has been growing.
Mm,
It is a telehealth platform that provides behavioral health sleep medicine programs, including CBTI. And currently they're operating in 40 states and they've been growing rapidly. So you can make a referral to that program and they'll take it over and run the program and you'll get feedback. But there's just more and more opportunities where to incorporate behavioral sleep medicine services, it really is if people value it, there's a way out there to do it. They just need to find it.
well, and that's a really important point too, right? The point you made earlier about how do nurses bill for their time, right? And for this work, but even just this idea of embracing behavioral health. I'm a little bit familiar with the Noctum platform, and it's my understanding that it uses RTM billing. Is that
Hmm.
your understanding too?
Yes.
Yeah. So that'll be really interesting to kind of see how that plays out.
I've walked through the program with
Mhm.
Dr. Germain. It's beautiful.
Mm.
I mean, it has a dashboard. You can track all the variables we track. It crunches numbers for you. But there's always a clinician in the driver's seat that decides if what the algorithm is suggesting is the right thing to do.
And I think there's an option too, if you don't want to be that clinician, that you can ask them to do that part too. Is that correct?
I believe so.
Okay. So then what about when you have to, modify CBTI? So in the past, we have spoken with pediatric providers, and they talk about needing to modify CBTI for adolescents, for example. So is this something you do too? Do you modify your CBTI?
Yes. And with a lot of the pediatric cases, it's not CBTI as we conceptualize CBTI. There are protocols for pediatric sleep disorders.
Mm.
So, like one of my favorite is bedtime fading with response cost,
Yeah, tell me
which
about
is,
that.
yeah, it's a wonderful and it works so well. And if the parents are on board and they follow the plan, children can get significantly better um, within a few weeks. There's different protocols for delayed sleep phase disorder, advanced sleep phase disorder. So there's lots of ways to modify it for the population. Even within CBTI itself, if you have a patient who has a seizure disorder or they have an unstable bipolar disorder,
Mm-hmm.
instead of doing sleep restriction, we do sleep compression, which is much gentler. It just takes longer.
Mm. And then is that something then I suppose you have that conversation up front?
Oh, yeah.
Yeah.
Informed consent is always necessary.
So tell me a little bit more about the bedtime fading. What do you do for that?
So with bedtime fading with response cost, you have the parents keep a log of the child's sleep. And what you're really looking for is what's the average time the child is going to sleep and what's the average time they're getting up at and when do they need to be up? And then you're calculating how much sleep they get. And so then you set a plan where they have an earliest bedtime and a latest wake time, just like with CBTI.
Mm.
But then what you do is the parent puts the child to bed and 15 minutes later, they check on them. If the child is asleep, great. If the child isn't asleep, they keep them up for an hour past their original bedtime and then put them back to bed. And again, if they check on them 15 minutes later, the child isn't asleep, you keep them up another hour. And so it builds this tremendous amount of sleep pressure. And then the way you adjust it is if the child fell asleep within the first 15 minutes, then the next night their bedtime is 30 minutes earlier.
Mm.
If they didn't fall asleep within the 15 minutes, then the next time their bedtime is 30 minutes later. And so there's the zigzag pattern, but gradually enough sleep pressure builds that you can add enough time in bed until the child is getting the sleep they need.
But if you're talking about delaying their sleep by an hour or two, don't you get a lot of pushback from parents?
No, not really.
Really?
Well, by the time a lot of parents come in, because there aren't a lot of pediatric behavioral sleep medicine providers out there.
Okay.
And so by the time the parents come in, they're desperate because when their
Huh.
child doesn't sleep, they don't sleep.
Yeah.
So usually they're willing to come in and follow the program. And I've even had parents who have negotiated, you take tonight, I'll take tomorrow night, and we'll alternate. But because it works so quickly, they really need to do it for a couple weeks before the child is retrained and sleeping better.
Is that all? Because I just imagine 2 hours puts it right into sort of the adult bedtime. Like if you're delaying it by a couple of hours, right? That
Oh,
kind of goes into the adult bedtime. So I'm surprised it only takes a couple of weeks.
well, but they build up a tremendous amount of sleep pressure
Hmm.
and they're not allowed to sleep in, nap, or go to bed early. So the difference between that and CBTI is CBTI, we're adjusting the schedule by 15 minutes every week.
Mm.
And with this one, you can get them to where they're so sleep deprived, they fall asleep earlier and earlier. And once you break that cycle, they start getting to where that demand for sleep is so strong, they fall asleep right away. And then you just expand out their schedule.
Hmm. Well, sounds like a relief for parents who are struggling with this.
It is. And it's fun for clinicians because most of them get better very quickly. And obviously, there are people or children who have complicating health conditions or
Mm-hmm.
comorbid conditions that might make it longer. But for most children, it's a relatively short process.
So tell me about BBTI.
BBTI is a wonderful protocol. It can be done by a variety of providers. We've trained LPNs, RNs, physicians, we've trained CCSHs. There's just a whole bunch of people that can be trained. And the beauty of it is that it's really a two in-person visit with two follow-up telephone calls. The Department of Defense put together this wonderful workbook that walks you through all the stages of BBTI. But it's something that can be done. And when they did research, I'm going to forget who did the research, but when they did, I think it was Edinger. When they did the research, they found that they compared one session of CBTI, 2 sessions, 4 sessions, and 8 sessions. And what they found was the ones that made the greatest statistical improvement in sleep were the 2 and 4 sessions.
Mm-hmm.
And so the beautiful part about BBTI is you give them these 4 sessions, you get them on track, you train them how to continue it on their own. And if they're satisfied, great. If not, then they can come on board and do the full course of CBTI. A couple of years ago, I headed up a work group with the Society of Behavior Sleep Medicine.
Mm-hmm.
And our idea was that we were going to go in and train residents in family practice
Okay.
to do BBTI. So we had, I think, 2 MDs and then 2 behavior sleep medicine people. And so we got it piloted at UCLA. The residents, there was only about 12 of them that participated. They loved it.
Huh.
But then they said at the end, they said, but I can't see how I can fit this into an office visit,
Mm-hmm.
given that we're seeing, 26 to 30 patients a day.
Yeah.
But, even when you look at it, like most physicians get about 2.5 hours of training in sleep.
Mm-hmm.
And most psychology programs do maybe an hour of training in sleep,
Mm.
but it's just not being disseminated. And so, when you talk about the shortage of providers, wouldn't it be awesome if in the psychology programs they had a class on sleep? Because it's one of those things that when you catch the bug,
Yeah.
it's amazing and you want to pursue it. But most people don't even know it exists.
I think, and I mean, you've hit on it. I've been in sleep for, 15 years, 15 plus. And some of the behavioral treatments you talked about, I'm not sure I ever knew those. Like the idea of I can I can collaborate with someone else to have those conversations with patients about, and their parents, right? About anticipatory awakenings and to kind of offload those really time consuming parts of our practice,
Yes.
right? With somebody who is skilled in motivational interviewing. So I feel like that's a really good collaboration.
Yeah. And so, like with this presentation I'm putting on for the practice management course, one of the reasons why having behavioral sleep providers available is how many of your patients have complex psychiatric issues.
Hmm.
And we do have sleep psychiatrists, but a lot of people don't have a lot of background in that. And
Mm-hmm.
then there's exactly what you said. A therapy hour for me is 53 minutes. You never get that much time with a person.
Yeah. What about our adolescents then, or people with delayed sleep phase syndrome? So tell me a little bit more about the circadian rhythm program you have.
So I love treating circadian rhythms. And interestingly, we don't get a lot of teenagers in with it, even though they have it.
Okay.
But where we really see is when students start missing classes in college.
Mm.
And a lot of them will just reorganize their schedules so that they can accommodate their sleep pattern. But then they hit that first job after college, and a lot of times that's when they're coming in. So the protocol for delayed sleep phase is really kind of beautiful in its simplicity. But what we do is we have them keep what's called an ad lib sleep log. So on days when they have to get up, they record their sleep as it is. But on days when they don't have to adjust their schedule, we have them stay up until they're reasonably certain they're going to fall asleep quickly and sleep until they wake naturally on their own. And once you have enough data points, you can calculate the average time they're falling asleep and the average time they're waking up. And then we don't obviously measure melatonin in the clinic. So we calculate the DILMO where we take the average time they're falling to sleep, and 2 hours before that is the estimated DILMO. And then 2 hours before that, so 4 hours before their average time to fall asleep, is when we would use low-dose melatonin if the person is wanting to do melatonin. On the other side of it, we figure out their average time awake, and we figure that 2 hours before their wake time is when they reach the nadir of their core body temperature, and we add an hour, and that's the time we start light therapy.
Mm.
And then what happens is, and people do it differently, but the general protocol is you set their original sleep plan, and then every day you advance it by 30 minutes. So their time to go to bed can move 30 minutes earlier if they're tired, but their time of awakening in light therapy always advances by 30 minutes. And what happens is, again, that sleep pressure builds, and it pushes that sleep onset earlier and earlier. Now, some people will do it where if 30 minutes is too overwhelming for the person, they'll do 15-minute intervals. But for most people, you can treat their sleep phase and get them on their desired schedule within a couple weeks. The problem is not, I always tell people treating delayed sleep phase is so easy. Getting people to maintain that schedule, that's the hard part. And so we get a lot of repeaters who come back and they're like, I went on vacation for a month. I'm back to where I started, and then we do the process again. But it's kind of like weight loss, right? People can lose weight, but the challenge is getting them to keep it off.
So when you talk about low-dose melatonin, what are you talking about?
So a lot of the research suggests that 0.5 to 1 milligram is adequate. The problem with this is in most states, behavioral health providers are not allowed to recommend supplements. It goes outside their scope of practice. So a lot of times we'll tell people you need to talk to your prescriber or your doctor, and if they okay this, then we'll proceed with that.
Oh, that's interesting. And then if I'm understanding you right, then when you first start the light therapy, it's an hour before they wake up?
Yes.
So how do you do that? Is that with like one of those alarms, like one of those sunrise alarm clocks?
Well, my favorite one for people who are really hard to get up is called the sonic bomb. It's a 117 decibel alarm clock, and if you have people set it up on the far side of the room, they're going to get up. But there's a whole host of things for people who are difficult to wake. I had a client just today who said she's using this new app called Alarmy, and you take a picture of an object in a different room and the alarm doesn't shut off until you take the same picture of that object and you match the two images exactly.
Oh my gosh.
There's lots of creative ones. There's things that send a helicopter across the room and you have to put the helicopter blade back in the alarm clock to quiet it down. There's just a lot of cool devices.
I thought Clocky was hilarious. That clock on wheels that like flies off of your night table.
Yeah. Well, and I always tell people if you really want to do something, you'll find a way. So there are tons of options for getting people out of bed.
So you're then making them wake up to do that morning light.
Correct.
Okay. I was thinking maybe it was sort of more passive than that.
No.
Okay. Okay. So let's take a short break, and when we come back, we'll talk more about behavioral therapies for sleep disorders. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Dive deeper into the future of sleep apnea therapy with the Apria Sleep Care program. Once we receive the PAP referral, our team springs into action, offering patients a seamless transition into therapy. Patients start by selecting how they want to begin their sleep journey: in-person care, virtual care, or self-directed care, with ongoing therapy support, including coaching, digital resources, and video assistance, we're committed to ensuring every patient's success. We stay connected with our patients with live calls, texts, emails, and IVR, all designed to make adherence a breeze. And with our supply schedule program, replacements are delivered like clockwork. Experience the difference of an enhanced sleep therapy program with Apria Healthcare. Discover more about our innovative sleep program online today at apria.com.
Welcome back to Talking Sleep. We're talking with Dr. Rick Blackburn about behavioral treatments for sleep disorders beyond insomnia. Tell me about other behavioral therapies like nightmare rewriting.
Yeah. So imagery rehearsal therapy is the name for nightmare rewriting. And it's based on this idea that when we sleep, we process memories. And nightmares are a learned behavior, right? You have this horrific dream that may be related to a trauma or may just be random. But because it's so upsetting, you think about it during the day and you go to bed fearful about it. And we know in REM sleep, that's when emotions are modulated. And so what happens is they dream and that nightmare comes back because it's processing new information that they thought about during the day. So what we do is we turn that to their advantage and we have them rewrite their nightmare. But at the point where it gets scary, they change it in a way that makes it less scary. So, for example, I had a woman who was involved in a car accident. And so at night when she was sleeping, it'd be black and she'd see these headlights coming right toward her. And then she'd wake up screaming. And so when we talked about how to rescript that, she wanted to have the Roger Rabbit car.
Oh.
So, the Roger Rabbit car
Yeah.
go up over things, shrink down. It's kind of like the bus now in Harry Potter. But she wrote that. And so we had her practice it for 10 minutes several times a day where she would vividly imagine that dream, only change it in the way that makes it non-frightening to her. And then gradually over time, her dream changed. So this was really, it was developed by Krakow quite a while ago, but it really got a lot of press with people returning from the Afghan and the Iraqi war. And the studies on it are remarkable. And in fact, a lot of people say it works better than Prazosin.
Really? That's impressive.
Yeah.
So when you say that you have her write it, do you mean sort of practice the imagery or do you mean physically write it out?
She writes it out in vivid detail.
Really?
Everything. Like you try to imagine it like it's in a movie and you write out exactly everything. So, your friend was sitting in the seat next to you, loudly chewing bubble gum or whatever it is. And then they read through it and they practice that intense script, only they change it at the part where it becomes frightening.
Huh. So this kind of opens up a lot of thoughts in my mind. I feel like my patients who have PTSD, and I'm thinking of especially military veterans who really struggle with PAP therapy, right?
Yeah.
It's sort of, a lot of people talk about flashbacks and they talk about, I did this in the military, I can't do this. So how can I help them with this?
So behavioral sleep medicine actually does a really good job. And what we do is we do basically systematic desensitization tied with motivational enhancement therapy. So let's say a person is claustrophobic and they don't like the feeling of the mask on their face. We don't tell them, put it on, hook it up to the machine and go to sleep. We start at a level where they're comfortable. So it might be holding the mask on their face without the headgear attached, just so they get used to that feeling. And if it gets too intense, then they can take the mask away and they just gradually work at increasing the amount of time they can tolerate that. And then for a second step, we might have them put the mask on with headgear, but the hose and the machine aren't attached, and they're not trying to sleep with it. They're essentially watching TV or doing something pleasantly distracting until they get used to the face mask and the headgear. And then what we do is we have them then do that again in front of the TV or something distracting, only this time they've got the machine on. And they're just getting used to the breathing part of it. So if you think about breathing, we pause after we take a breath and we pause after we exhale. And the problem with CPAP, especially the CPAP, is when you're trying to pause, the machine is forcing air in. And so it just takes a while to get used to breathing with the machine. So we just have it do it when they're awake and they can take breaks if they need to. And once they're able to wear it for like an hour with the pressure, then we have them take a PAP nap, right?
Mm.
So you're just going to take a brief nap, half hour or so, and you're going to use the mask for it. And then when we get ready to transition them at night, I usually have them do it on a non-work day.
Mm-hmm.
And I'd say stay up until you're so exhausted you can't possibly stay awake anymore. And then go to bed and put on your CPAP because then that added sleep pressure helps them fall asleep. And it's just a matter of getting used to it. But the motivational enhancement really is, if you think about CPAP, it's not sexy. It's not always comfortable. And people have all sorts of reasons about why they don't want to do it. So then it's working with them on exploring that split or ambivalence between I want to breathe and I want to feel better during the day, and I don't want to use this machine. And basically, then you're trying to enhance it. You're educating them. Here's what the statistics say about what's going to happen to you if you don't use CPAP. Here's your risks of cardiovascular disease or stroke or diabetes. And it really is just getting across to them that, yes, this is difficult. It's okay to struggle with it, but you really need to get used to using this. And so for most people, taking that slow, gradual approach works amazingly well. The place where you run into problems is obviously with Medicare and their compliance
Mm-hmm.
requirements because it doesn't give you a lot of time to get them broken in.
So I feel like what you've described is, kind of CPAP desensitization.
Mhm.
And where I'm kind of wondering is there something a little bit different that we might do for our military veterans who, like we were talking about that part where you just put, you hold the mask and you put it in front of your face, when that is what they can't get past? Do
Right.
you then combine it with imagery rehearsal, or how do you overcome that?
So again, with systematic desensitization, you find out where they're at. And you might start with let's say it was a pilot and they were wearing a mask and they got shot down,
Mm,
right? That mask itself can be a trigger.
right.
So then you just have them be in the room with the mask and you work with them on anxiety management skills, breathing, guided imagery, anything that helps calm them down. And then just like how we treat spider phobia, you bring it closer and closer and you make it more realistic. But the whole way you're doing that, you're teaching them how to self-soothe, and then you're taking that next step. And so it can be a really long process.
Mm-hmm.
But really, it's that idea that you start where they're at and you have them work with you to incrementally increase it until they get to the point that they can use it. And it might even be, if it's a PTSD reaction, you might have them working with their trauma therapist or an EMDR therapist. And some of those sessions might just be about, I'm traumatized by needing to wear this mask.
Right. Right, because in my mind, that is almost the point where, um, is it worth going down that road, or are they a candidate for some other treatment, like a mandibular advancement device or something like that?
Yes. Yeah, and I mean that's part of it is exploring the options,
Yeah,
whether it's Inspire or a MAD device,
yeah,
positional therapy. The one thing about people with or who are veterans is they have a much higher rate of sleep apnea.
right.
And what the research is kind of suggesting is it's because of the medications they're taking that are sedating to help them with their anxiety and their PTSD. So it's like their apneas are longer because they're slower to wake up because of the medications.
Well, and it just feels like, they feed off of each other, right? They're not sleeping as well, and then the PTSD gets worse, which makes it harder to, think about treating their sleep apnea. And so I was, I've always kind of been thinking about, well, how else can we help to break that cycle and help our patients get on treatment, and not maybe just say, ugh, everybody wants to put me on a CPAP. I don't want to do that,
Right.
and I love this idea of kind of helping them address the PTSD component, and the anxiety management, I think is really important.
So there was a seminal paper done called the Sleep to Forget, Sleep to Remember program.
Mm-hmm.
And it really explains how the brain modulates emotions during sleep. But what a lot of the research is showing is that, especially with the exposure therapies like prolonged exposure or EMDR, if you improve their sleep, they'll generalize what they learn in therapy more broadly and they get better results.
Tell me more about EMDR. How does that work?
EMDR was developed by Francine Shapiro back in the 90s, and it was her doctoral dissertation. And she was walking one day and she was thinking about distressing thoughts. And according to the story, she was looking side to side, and that bilateral stimulation calmed her. And so what she did is she started doing research, and initially it was just with eye movements. But the idea is just like when we dream, it kind of drains some of that emotional um, tone out of it, that they're basically mimicking the saccadic eye movements of dream sleep. And so when they're focused on thinking about what's traumatic, they get that um, decrease in emotional tone that helps them then process through the memory. And they've moved on now. They found that bilateral stimulation, like with using vibrating eggs in each hand or tapping, can also help. But it really was. Bob Stickgold did some amazing research on this. And early on, when I was doing my dissertation, he helped me. And one of the things he was talking about is that basically it's mimicking REM sleep and you get the benefits, except you get to choose what you're focused on.
Mm. Yeah, I've had patients who have done it that had really great results, but sort of the process was hard. Yeah. So, what about fatigue management? Tell me about that.
We do fatigue management, but a lot of times it's in combination with the medical treatment. So they're on modafinil or a stimulant of some kind.
Okay.
But basically, even with when it's medically managed, there's still that residual fatigue that's really difficult for people. So most of what we do is we might do a little CBTI to improve their sleep at night, to make sure their sleep efficiency and sleep quality is good. But then we'll have them track when their sleepy periods are happening. And sometimes it's random, but for a lot of people, it's around certain times every day. And so we work with them and their prescriber to find the optimal time for taking their wake promoting medication regarding that. And we might even do, like a modafinil nap where they take their
Mm.
modafinil and then we have them take a 30-minute power nap to bleed off sleep pressure. And then when they wake from that, then they have the medication in their system to help.
So, this is really kind of fascinating to me because I hadn't considered um, using a behavioral therapist to help with fatigue management, right? We're always trying to figure out, okay, what time are you sleepy? When should we dose your medication? And so it's lovely to have this, potential resource, right?
Right. And a lot of the behavioral health sleep medicine treatments are perfectly aligned to work with a sleep provider for it.
Mm.
So even like, I know sleep providers really don't like long-term Z drug use or other medications. And and so we can work with that provider to do CBTI while also simultaneously doing a medication taper. And it works very, very well. But there's lots of overlap between what sleep physicians do and what behavioral sleep medicine providers do. So even like with CPAP compliance, right? Compliance is about 40%. But if you had a person who is trained to help them be more compliant, it would improve the patient outcomes, the provider outcomes, and it's a win-win. Again, the issue always seems to be that either sleep providers don't know all of the services that behavioral sleep medicine can provide, or they don't know how to access one.
Well, and I think both of those are so important, right? Because I think once we have had years and years of trying to embrace CBTI, and if we don't have somebody sort of in our region, then I think it just becomes a frustration.
Yeah.
And then we don't explore these other aspects. Like I've never thought about these other aspects that you've been describing. Like I'm not sure I ever would have thought to refer somebody for a circadian sleep-wake phase disorder.
Right. We also have excellent protocols for dealing with non-REM parasomnias.
Oh, tell me about that.
So a lot of it is, like with sleep tears, we do is we have the parent track the times that these are having, and we come up with a window of time. And, like sleep tears are typically in the first third of the night.
Mm-hmm.
And once we find out when those events are typically starting, we do a scheduled awakening a half hour to an hour before it. And whatever it is about that, it disrupts it. And then the sleep terror doesn't happen as much.
So you're talking about the anticipatory awakening.
Yeah. So scheduled awakenings work really well for sleepwalking, for sleep terrors. It even works well for bedwetting, right? You find out what time the child is wetting the bed, and you wake them up before that. And because children have slow wave sleep at tremendous amounts, they often don't remember being awoken. You take them to the bathroom, you put them back into bed, and usually they're back out. But it's just enough to disrupt that process. The other thing is, educating the parents. Mm-hmm. Sleep terrors are frightening, right? And the parent always tries to comfort the child or wake them up, and that causes more agitation. So it's helping the parents understand what this is, that it's not some big psychological trauma, and how it happens, and then best ways to respond so that they don't make the events worse.
What about RBD? What can you do for that?
Not a lot.
Oh.
Well, but
that's not what I was hoping to hear.
So my big thing with RBD is to screen for it with every patient. Mm-hmm. Because we obviously know that, within 12 years, 90% of RBD patients are going to have a degenerative disorder like Lewy body dementia or Parkinson's. And so what we really do is we can't definitively diagnose it because you need a polysomnogram to do that. So we connect them with a sleep provider, but we also start facilitating a referral to a neurologist mm-hmm. so that they can be tracked throughout the course of this. We can do things like safety planning with the patient, environmental modifications. I have a friend who has it, and he ripped his TV off the wall. He put his head through a couple walls, actually broke his nose twice, had a couple. It was
oh my
really
gosh.
disruptive.
Yeah.
And so we worked at modifying his environment, especially since he had a cervical fusion. The time he hit the stud was just bad.
My gosh.
We worked on that. We put in alarms so that when he got up, we trained his wife, if this happens, here's how you deal with it. And then we got him to a sleep physician because ultimately clonazepam won out.
Mm-hmm. Yeah, I guess I didn't realize that there was so much more to behavioral sleep medicine than, CBTI.
Yes. CBTI is what made it popular, but for most sleep disorders, there's a lot we can do for it. So yeah, CPAP or a mandibular device is great, but they both have poor compliance rates. But because we're used to motivating people through therapy, it's a natural fit.
Huh. So how can we incorporate some of these therapies that you've described into our clinics? What things do we need to think about? Is there something in the EMR? how does this work?
Well, the EMR is a great place to start because our sleep therapists are billing um, the CPT codes of behavioral health. And a
Mm.
lot of sleep centers don't have that built into their billing system.
Okay.
So modifying the billing system so they cover the behavioral health CPT codes would be a great step for sleep centers to take so that if they do bring on a person, they can actually bill for it.
And so I'm now thinking about my own practice where there's no way I could bring someone in, but I could refer out. And
Yeah.
so then can all of this be done via telemedicine?
Oh, yeah. Even the research says in person is as effective as telehealth. Um, the digital CBTI platforms don't do quite as well as in person or telehealth. And we think the reason for that is because a huge part of beginning like CBTI is the first several weeks are miserable and they're tough.
Mm.
And so, really, it's that being accountable to a person, getting that personalized feedback, but also having someone who's motivating you to keep going and to address your fears and concerns. And so there's a lot of programs now that are digital that are creating dashboards so providers can follow along. But it really is, I always tell people, for CBTI in the first week of therapy, I can reduce the time you're awake during the night by half to two-thirds, but you're going to feel like you got hit by a bus.
Oh no.
Follow the modified plan the second week, I can reduce the time remaining that you're awake during the night by half to two-thirds again, but you're going to wish the bus would come back and finish the job.
Oh
By
no.
the third week, you should be getting as much sleep as you were getting at the beginning, just in a shorter period of time. And then it gets easier after that.
Mm.
And when we look at the dropout rates, it's very similar to psychotherapy. About 40% of people who start CBTI will drop out. But most of those dropouts happen in those first 3 difficult weeks.
We had an insomnia summit, I think a couple of years ago, and there were representatives from, I think, almost 50 professional and patient facing organizations. And the take home messages from that day of, conversation back and forth and addressing this issue of insomnia care was access to care and how do we improve the pipeline and how can we be creative about ways to deliver care. So you've kind of hit on, digital CBTI and telemedicine and improving the pipeline. And I think those are all really important considerations.
Yes. And, going back to your remuneration question,
Mm-hmm.
behavioral health does reimburse less. So I have as many years of school as an MD does, but we are paid nowhere near the same amount. And so a lot of times people are drawn into these specialty practices or they go just to private pay. And like most of our providers here in Minnesota that were in my training cohort that I was trained in, they've gone to private practice and
Yeah.
self-pay only because
Yeah.
they're not limited by the insurance reimbursement.
Yeah, I mean, it's a problem. I think Dr. Martin had talked about advocating for, and this would be for, physicians and clinicians to bill E&M codes for CBTI.
Yes. Yeah, that would be wonderful. And I did read that article where they
Mm-hmm.
recommended that. The other thing you're finding is that outside organizations have the same problem you do, even if they have behavioral sleep medicine providers, it's not enough to meet the demand. So,
Mm.
two of the largest health systems here in Minnesota, between them, they have a 2,500 person wait list.
Holy smokes. Wow.
Right. And so people are finding out about CBTI. They're hearing about it from their doctors and they're like, "Well, I've tried everything else. This sounds like a good thing." And
Mm-hmm.
research shows us that patients prefer a behavioral treatment over a medicinal one. But then you got to wait a year and a half to see a provider. Well, that's not going to change our paradigm because our current practice is here's a pill for that.
Mm.
So it's both an access issue, but it's also a the demand is growing. There's just not enough providers to meet that demand.
Yeah, and isn't it funny? That's such a frustration because here we are embracing this idea of how important sleep is, and there's a lot of media attention on it and lots of consumer-facing devices. And yet, if you have insomnia, please wait 6 to 12 months to go see somebody about it.
Right. Yeah. And I mean, we know patients are already frustrated with the time it takes them to get a sleep study and
Right.
get their results. And that's often much shorter than it is to get to CBTI. And it's not like they can't get in. Like with those two health systems, they have this long wait list, and yet I'm sitting here with therapists with unfilled therapy time. But a lot of time, these large health systems don't like to refer outside their network.
Oh, that's interesting. It surprises me that you have therapists with unfilled hours.
Yeah, and we're always training more, and
Mhm.
we're working with some of the healthcare organizations to take some of their wait list down.
Yeah.
It's like the therapy's there when patients come in, they love it, but they're also not hearing about it. When the 2016 consensus statement came out from the American College of Physicians, everyone was talking about it, but then they couldn't find a provider, so then they forgot about it.
Mm.
So, I mean, part of this is even like with what you were saying today, we provide all these services that can help you do your job better. Like we'll help them get compliant with CPAP. But even sleep physicians don't know all of what we do. So they don't send the referrals.
Yeah. No, you're exactly right. I learned a lot from you. So what is it that you would like us to remember about this episode? Do you have a key takeaway for us?
Yes. If you really want to have behavioral health sleep medicine providers, you'll find a way to make it happen. There's tons of opportunities out there. There's private practices. PsyPact is this new thing that allows psychologists who are licensed in one state to work in 40 states that
Oh, wow.
PsyPact. So it reduces those jurisdictional things. The Society of Behavioral Sleep Medicine has a list of telehealth CBTI providers. And there's, I think, 2 states that don't have a CBTI provider. One of them, South Dakota. But most of the rest have some. And then there's even things like we have lots of providers who are trained in CBTI, but they're not registered with any of the lists. And so how do people find them then? But with things like Dr. Lullaby, or these other online platforms or digital CBTI, it may not be as ideal as seeing a provider face to face, but it's still better than nothing.
Well, thank you for joining us today and for highlighting both behavioral therapy for insomnia, but also other sleep disorders like circadian rhythm sleep-wake disorders.
Well, thank you for having me. I appreciate the time.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.